Okay.
Go ahead.
It's a great pleasure to share my knowledge with the WebSafe community. My topic today is a very classic subject, the control of the inferiors incisors in class 2 corrections, but I would like to enlighten it by the use of our modern tools, I mean TADs. I would like to start with a short presentation. My office is in a small town of the middle of France, open since 2010. It's a beautiful area near two very rich departments for their landscapes and their culinary specialties. Brive was a breadbasket for France during war. Here is my office and staff, along with my associate, Dr. Bayer, on my staff. We are Virginie, Tatiana, and Vanessa. So it's a small office, but a very good working environment. In France and more widely in Europe, we have 60% of patients who are in class 2. Having control of the mandibular incisors is one of the main goals of our treatment. In association with vertical molar control, it determines the quality of skeletal response of our class 2 treatment. It also takes part in the control of the occlusal plane, and it's essential for the preservation of the periodontium in the frontal area. Therefore, mandibular incisor control represents the key to our functional, aesthetic, and periodontal goals, as well as determining stability. The use of TADs enables us to achieve these goals in a context of treatment without premolar extraction. Through key decision criteria for rational mechanics, we will see how to optimize our class 2 treatment by contouring the mandibular incisor. 2 years ago, I have received and transferred this patient. We don't know what happened, but what is sure is the incisor should not be centered in the mandibular symphysis at the end of the treatment. Thinking of the inclination of the tooth, we could find good cephalometric position, but it's out. To my mind, it is not a simple question of prescription, but a biomechanic failure. So even if we have a slight crowding, alignment always promotes the centering of the incisors because they are going towards low resistance areas. It follows a transversal expansion, well supported with Copernicus wires and much more critical sagittal expansion. And class 2 biomechanics will accentuate the incisors' decentric position. This patient has been treated without skeletal anchorage. His parents preferred that we didn't use mini screws. He has a full class 2 treated by a class 2 activator, followed by braces and protractor. So here is the outcome with a class 1 finishing, but a gummy smile, and a projection of the lower lip. In fact, we can observe the clockwise tilt of the occlusal plane and the labial version of the incisors, both consequences of the class 2 mechanics. So, what are the key to enhance aesthetics in class 2 malocclusion correction? We have to promote the best maxillar position to expose the smile and enhance the mandibular growth. Thus, we have to determine which place for the maxillary distalization. If we make the choice of alveolar decompensation, we will be able to promote the mandibular response and get a better integration of the chin and the profile. We will reduce the need for maxillary retraction and better the sagittal position of the maxillary incisors with less torque to reach the class 1. Contrarily, mandibular sagittal expansion reduce the mandibular response possibilities and increase the need for anterior torque to achieve class 1. So what do we have to control and focus on in class 2 correction? Our decision-making criteria are always founded on clinical and cephalometric analysis to determine the class 2 origin and typology. If we make the choice of alveolar decompensation, do we need transversal expansion? And it's not only a question of maxillar transverse deficiency, but it's also depending on your repositioning goals, because the more you have to distalize the lower molars towards the posterior alveolar area and the angles, and the more you increase the intermolar width. So you might anticipate to avoid the operation of a crossbite. Could we get incisor repositioning by class 3 elastic stretch from maxillary meniscus, or by arch retraction with mandibular meniscus? Concerning the vertical control, we need to assess the alveolar height anteriorly and posteriorly to determine the occlusal plane orientation and equilibrate the annular schema. Therefore, we have to assess the position of the stomion and how the smile is exposed. Our main goals is to optimize growth by helping counterclothes rotation, and also getting good maxillary positioning to expose the smile. Finally, we need to protract the mandible, and in this case, we have to control the side effects of our biomechanics. To my mind, whatever the chosen mechanic, the incisor centering need to be anticipated and the occlusal plane observed. We all know that there is an interaction between 3 main goals: the mandibular incisor centering, the occlusal plane control, and the maxillary incisor exposition. That has been developed a lot in Asia with 2 main goals, I think. The posterior vertical control and the molar distalization to easily treat patients with class 3 malocclusion, hyperdivergency, and eye discrepancy. Then they have been used for the control of traditional mechanics, and regarding to their specificities, we need to optimize their use in hyperdivergent patients. Our own masters had a good understanding on all the facial growth process. Crickmore said something like that: if we were able to control molars, we could treat roughly all the malocclusions. With that, the vertical control of molars is always present unless mechanic schemas with high anterior hooks or vertical bands in the wire to compensate. This fact induces a choice to do for maxillary or mandibular anchorage. In the past, I was often anchoring the maxilla by meniscus with headgear effect exacerbated and consequently a smile line often too much lifted. And you can see that fact on the second picture. So all these patients have been treated with maxillary anchorage. As the smile line has been lifted, the smiles look aged, and we need to stop that. The more we move back the maxillary arch, the more we decrease the posterior maxillary alveolar height, so the more the smiles goes up. And we know that the occlusal plane in mesodivergent patients should be tangent to the occiput and the stomion positioned 2 or 3 millimeters from the edge of the maxillary incisor. Here, a very interesting article published in the AGODO. All the situations have been evaluated and we can understand that the direction of the anterior traction determines the incisors' behavior as well as their vertical control. On these X-rays, we can see the effect of a mandibular retraction with mini screws on the incisors and on the ingression of the molars. As we have obtained a counterclockwise rotation of the mandible, the lips are now relaxed. The inferior incisor control as well as the posterior intrusion allowed the vertical closure of the compass. When you want a counterclockwise response of the mandible, you need to be aware of the molar's antagonist extrusion in monomaxillary anchorage patterns. If the muscles can counteract this extrusion, you should anchor it twice, on the lower and on the upper arch. In class 2 correction, you must adapt your mechanic to the vertical typology, to the situation of the maxillary incisor, anterior-posteriorly from the frontal plane of Sassoon and vertically to the stomium. We adapt the centering of the incisor, of the inferior incisor. We see where the apex is, and we make the choice to make a translation or a version. To change the behavior of the incisor, you can change the length and the position of the anterior hook. And we have a choice to do between upper mini screws and class 3 elastics, or lower mini screws and mandibular protection or class 2 elastics. So we will see now when we could use maxillary mini screws expecting a headgear effect. Here is Alicia. She has been treated by a two-step treatment. She was 10 at the beginning of the treatment, and she has the skeletal class 2 and was mesotrend with an hypodivergent tendency. On the intraoral view, we can see she has a maxillary transversal deficit and a class 2 molar relationship with supraocclusion. The X-rays show skeletal class 2 by mandibular retinosclerosis. She has meso with a brachy tendency. She has a protrusion of both incisors and a supraocclusion. She has been treated with a class 2 activator, and we see her again in a permanent dentition. So now she has a class 2 subdivision, not only due to the rotation of the 35, but also because of deviation of the mandibular midline with an interincisal maxillary point nearly centered. Her face, and you can see her chin with a small symmetry. And this smile is nicely positioned, and we know we don't have to move the smile line nor the maxillary incisors. So here are my guidelines that help seeing the posterior alveolar height, SNA, SNB, AMPA, and the maxillary incisor inclination to the palate and to SNA, but also to the frontal anterior plane of Sassoon. This plane is perpendicular to front 4 and joins the cutaneous glabellar point. Before, I was using the analysis of Stener and Tweed, but the skeletal anchorage specificities require adaptations. So it's a mixed analysis, finally similar to an architectural analysis. So we have to control the mandibular alignment with class 3 elastics anchored on the maxillary screws. Here the advancement of the treatment. Then a mandibular protector with an asymmetrical activation is needed. Here I put the American Orthodontics boroscope in place for 6 months. The asymmetrical reactivation is realized by crimpable shims on the class 2 side So it's a gradual activation. You can see, yeah. We can then compare the different X-rays at T0, T1 before mandibular protection and T2 after protection. The control of the incisors is good. And we have also a good equilibrium of the in-law schema. What can we see on this superimposition? We have superimposed the palate with a posterior registration on the pterygoid apophysis and stable osseous landmarks. So it's a best fit registration. There's no strain on the maxillary growth, and the alveolar bone age are respected without descent. And we have a good mandible response. You can see. In these slides, you can see the respect of the mandibular incisors positioning and the contact device response of the mandible made noticeable by the difference of the age of the lower part of the symphysis. So we have a contact device rotations. Here is the outcome at the end of the treatment with a class 1 relationship. We have a good exposition of the smile and the midlines are well centered. Here, a face at the end of the treatment and a smile with a good centering of the midlines. And the chin now is perfectly centered. Let's see now the case of Camille. She was 12 at the beginning of the treatment, and she has a well-positioned smile and a slight misalignment of the maxillary midline. In the intraoral views, there's a unilateral class 2 on the left side, and the misalignment of midline is very slight. The class 2 is due to an asymmetry of both maxillar and mandibular arch, and due to an occlusal tilt, occlusal plane tilt, which brings the mandible to a distal position. And it's often the case in class 2 subdivision. The X-rays show a skeletal class 1 associated with a mandibular asymmetry and a mandibular proconation. The maxillary incisor is slightly advanced to the frontal plane of Sassoon. So what are the levels of this case? The mandibular arch asymmetry is not so important, and the tilt of the mandible is due to the tilt of the maxillary occlusal plane. So the yaw is a functional consequence. The specification, to summarize, we have a class 2 biomaxillary asymmetry, predominant to the mandibular arch asymmetry, a slight tilt of the maxillary occlusal plane, a misalignment of the maxillary midline, and no mandibular crowding. So our treatment planning will be upper alignment, maxillary meniscus insertion between 5 and 6, mandibular bonding, leveling with class 3 elastics, control with 2.5 ounces followed by 4.5 ounces stretched from meniscus, distalization of sector 2 with a coil of 150 grams and 5 millimeter length, asymmetric elastics. It's for class 2 maxillomandibular resolution. On these intraoral views, we can see the mechanics with a vertical connection between the wire and the screw, which with an elastometric strain on the right side and a rigid connection on the left side to control the tilt correction. The left class 2 is corrected by the action of the class 2 elastic and the unilateral maxillary retraction. So here is the outcome after debonding with a good class 1 relationship, a good centering of the midlines, and our face, and a smile with a good exposition and symmetry. We can see on the X-rays our outcome with a good control of the mandibular incisor, which is less proclined, and a perfect position of the maxillary incisor tangent to the frontal plane of Sassoon. Here's the superimposition. They show harmonious growth of the face with counterclothes rotation. No stripping is needed here for the incisor repositioning. It's only biomechanics. After 2 years retention, she has always a well-balanced occlusion in a class 1 relationship. A good centering. And the lateralities are equilibrated on. She has a unilateral alternated mastication. And these functional outcomes are a key for stability. After 2 years, her smile is nice and well exposed. And she has still the mandibular splint. Here's the last X-rays and superimpositions with a low vertical growth pattern and counterclockwise rotations, both maxillar and mandibular. The superimposition of the condyles show a good respect of the alveolar crest and the cortical bone. No descent here. Our maxillofacial growth is continuing with a slight counterclockwise rotation. So this is an harmonious development. Another case with Emily. She was 13 years old at beginning and has a class 2 with crowding. As we can see, she has an asymmetrical class 2 with a maxillary deviation of the midline and an ectopic canine. There's no possibility for expansion in her case. The X-rays revealed a posterior maxillary deficit and hypodivergent tendency. She has a skeletal class 1 and biproconation of the incisors. The maxillary incisor is well positioned to the reference line of Sassoon. The angulation of the teeth in the sector 2 was favorable to a spontaneous correction of the class 2 molar relationship during alignment steps. And at the beginning, our compliance for the elastics wearing was very bad. Then she understands she needs to help me. She also starts lingual re-education. These two conditions need to be fulfilled to increase the overbite by plans closure. So here are the occlusal outcomes with a good class 1 molar relationship. It is a phase at the beginning, and we can see now the evolution of a smile with a nice exposition at the end of the treatment. However, there is still a proconation in this case. The soft tissues are well positioned and the upper incisor is placed on the frontal plane of Sassoon. Now we have to discuss about the use of mandibular meniscus. We have to recognize two different situations of class 2 malocclusions. In the first one, the specificities are patient hypodivergent, slight maxillary proconation, the stomion is okay. We have a posterior maxillary growth deficit, a mandibulary proconation, or crowding. In this case, we need to make the choice to put the meniscus in the mandibular arch. And we use class 2 elastics or mandibular protection according to the mandibular rectonatism importance. So you have understand that in this case, we will not put the screw in the maxilla, but instead we will utilize a mandibular schema to allow for maxillary growth with counterclockwise rotation. The occlusal plane has an anterior rotation center in this schema. So we also have a mandible anterior growth, and we know that is the best way to have a class 1 in hypodivergent patients. We can find this fact in the study of growth by Laverne and Gasson. The extrusion of the maxillary molar is well compensated by the condylar growth, which is stimulated by the temporomandibular joint decompression. It's different in high vertical growth patterns and hypodivergent patterns. When the specificities are high alveolar posterior height with maxillary proconation and high stomion with a gummy smile, you should insert the mini screws in the upper arch. But if there is also mandibular crowding, a mandibular proconation, and if we need to protect over 3 millimeters, we also should anchor the mandible. In this situation, we want to promote mandibular counterclockwise rotation, and we have the possibility to combine maxillary retraction and mandibulary protection. Depending on the strength of the elevator muscles, we could choose a first option with maxillary mini screws between 5 and 6, or in case of low strength, typically in high alveolar posterior height, we could choose a 4-screw schema to avoid the compensating molar extrusion. The goal is to obtain a counterclockwise rotation of the mandible by reducing the alveolar posterior height. The less favorable the growth is, the more it requires a posterior vertical control, but also interior. It's a question of mechanical closure versus condylar growth. The center of rotation is posterior to close the compass. Shorter is the anterior hook and higher is the vertical component. As a consequence, the occlusal plane is lifted. Let's see some case. As shown, Valentin has a class 2 with crowding in a class 1 skeletal pattern. The intraoral photographs show an occlusal class 2 with crowding. The class 2 is not complete, but about 4 millimeters. So we aim to distalize the molar for crowding correction. On the X-rays, we can see he has the skeletal class 1 and he has maxillar discrepancy. We have made the choice to use maxillary mini screws to distalize the molar just for alignment needs. At this time, I didn't focus my attention on the occlusal plane orientation, so I didn't see the vertical deficit in the maxillary posterior area. And the particularity of this case was that it was very easy at each appointment because we just had to check to see if everything was okay. At the time, I had forgotten that I aimed to distalize only for alignment needs. So we continued to distalize the upper arch, and the next slide will show what goes wrong with this case. At the end of the treatment, he has an occlusal class 1. We have bonded mandibular splint, and he has a maxillary plastic retainer for night. As we have retracted more than our initial goals, we can finally observe that the smile has gone up a little. On the profile, we can see that he has proconation of the lower lip, and we will see why on the X-rays. More than this, the X-rays show precognition of both incisors, as well as the lower lip. We should have removed the maxillary screws, put them in the lower arch, and retract the arch for 4 months in association with class 2 elastics to keep the occlusal class 1. As can be seen in the growth pattern, the maxillary vertical anchorage is too strong. We would get better results with mandibular anchorage in regards to the occlusal plane orientation, the posterior alveolar height equilibrium, and to the incisors inclination. So to summarize, with the cephalometric analysis, there's a residual biprecognition, the decrease of facinae, and the height inclination of the upper incisor towards the frontal plane of Sassoon. The maxillary vertical control is too high. We need to know when anchorage burn becomes a necessity. Here, the maxillary retraction is too important. The solutions are simple. Move the screw to the lower arch as soon as the cording is resolved, and obtain a correction of the residual mandibular proconation. After that, finish the occlusal class 1 using class 2 elastics. This is Valentine's Bordeaux. His smile is not really poor, but we know that we should try to avoid its retraction. He presents an asymmetric occlusal class 2 with maxillary crowding. The X-rays are showing a skeletal class 2 biomandibular rectonatism, which is compensated by a mandibular proconation. Disappointed by the default of smile exposition of his brother and the excess of lower lip proconation, I have chosen another biomechanic option with lower meniscus. We are also presented with a case of low vertical posterior growth. In this growth pattern, we must induce counterclockwise rotation of both maxilla and mandible. The occlusal plane center of rotation will be anterior, allowing the exposition of the maxillary teeth. The mandibular screws have been used to control the alignment and centering of the incisors. On the maxillary arch, 2 anterior bite blocks have been bonded to enhance growth and facilitate the overbite correction. Class 2 elastics are applied night and day, 2.5 ounces to 4.5 ounces. And now a smile has a good exposition. If we compare the X-rays, we can observe a decrease of the lower proconation. The arch has been retracted without wisdom teeth extraction, and there is no stripping of the anteriors. As a result, we have obtained the class 2 correction without reverse effect and a good projection of the maxillary incisor tangentially at the anterior Sassoon plane. The cephalometric analysis showed that there is no back movement of the A point. The maxillary incisor crown is tangentially oriented to the anterior plane of Sassoon, and this fact can ensure a good exposition of the smile. Leo is another patient with a large smile and a good exposition of the maxillary teeth. The profile photographs show that he is also in class 2. These intraoral views are the re-evaluation status and show class 2 and the situation after expansion. This stage was knit by transversal compensations and retained cuspid ricks. On the X-rays, we noticed that we have the same lack of maxillary vertical growth. The alveolar posterior height is decreased compared to the mandibular alveolar posterior height. You can see it there. We have a mandibular preclination, but there is no maxillary compensation. There is also an increase of the overbite. So now we have to make our choice. First situation, we have lack of maxillary posterior alveolar growth. He has a low angle growth pattern with upper and lower preclination. So we will opt to use the mandibular meniscus. We could enable the posterior maxillary growth by the association of inferior meniscus schema and bonding of anterior bite blocks. The bite blocks will help to level the curve of space and to allow showing in class 1 relationship. At first, we use mesial cuspid hooks, and then we use mesial cuspid hooks for lingual version of the inferior incisors, and then we distalize the traction point to continue with bodily movement. We can see on the X-rays the importance of the inferior incisors recentering without any stripping or extraction. The wisdom teeth are still there, and they participate in the distal growth of the arch. Moreover, the maxillary incisor is perfectly positioned to the anterior frontal plane of Sassoon. The incisor recentering and the retraction is fully compensated by the posterior growth of the arch. Finally, we just need light recentering of the incisors and a good reflection on the occlusal plane to optimize the growth rotations. We use the existing levels. In this case, the MPA has decreased about 8 degrees. He smiled during treatment, and here are the outcomes at debonding. And his smile is always laughing, and it's quite difficult to get a good picture of his smile. Now, let's turn to biomechanics reflection with the consequence of the entire hook's position, the necessity of extraction for inferior incisor recentering. When we talk about centering rather than repositioning, we take for reference the symphysis. I mean the all the bone. So 3 situations can be encountered. In the first situation, the apex is well positioned at the center of the symphysis. The defining issue will be how long do we need to apply class 2 biomechanics? In situation 2, we need to avoid any labial movement of the tooth. There is a labial risk of dehiscence. So we need to retract with bodily movement. We should choose a schema with mandibular meniscus and a distal cuspid hook with 6 millimeter length. In situation 3, the tooth is proclined with a distal position of the apex into the symphysis. We want a lingual version and have 2 possibilities depending on the vertical control of the incisor expected. With the class 2 elastics on upper meniscus, there's an extrusive component, which is useful in open bite cases, contrarily in deep bites, and when the stomion is low. A schema with mandibular meniscus and short mesial cuspid hooks is the best choice. In each case, pay attention to the height of traction and therefore to the situation of the mucogingival junction line, which influences the displacement. So now you are probably wondering if we still need extraction. At first, we have to assess the posterior discrepancy. We have to check the posterior alveolar space, the residual posterior growth, and the facial depth. Then it's important to observe the evolution stage of the wisdom teeth germs. If it's a coronary germ, you can conserve it. But if the roots have begun their edification, you must extract them. To illustrate these ideas, we will continue with Adrien. Adrien was 11 at the beginning. It's a two-step treatment. He was also in class 2 and has supraocclusion. The X-rays show skeletal class 2 by mandibular retinosism. He is hypodivergent. He has alveolar compensation and supraocclusion. So we are treating him with class 2 activator in step 1. He had the monitoring growth step and an eruption incident has occurred with his 35, and we decide to pull it. He is now in skeletal class 1, hypodivergent with mandibular proconation and a maxillar retroclination. After leveling, we are near an occlusal class 1 with maxillary spaces, and we have taken X-rays at this step. The X-rays show a sagittal expansion of the arch, and the inferior incisor is bordered to the labial cortices. We decide to recenter it by a total arch retraction on posterior meniscus with short hooks placed mesial cuspids to maximize the repositioning. We should have reborn the right bite blocks, but he has no discomfort. He was wearing class 2 elastics during all the mandibular retraction. Finally, we have obtained the appropriate incisor repositioning without any extraction, but he had a good facial depth and posterior growth, and these were very favorable conditions. So I think it's a big difference. Let's look at another cases with Tom. Tom has an occlusal class 1 relationship, probably due to alveolar compensation. And the X-rays are showing a skeletal class 2 by mandibular retinosism with alveolar compensations. The mandibular incisor is procline. In this case, we need to unlock the mandibular growth by the alveolar decompensation. Then we apply the same schema with mandibular arch retraction. I think the screws have been inserted between 6 and 7. And in the retraction is associated with class 2 elastics. So we have obtained an important repositioning of the inferior incisor. And if you look at the wisdom teeth, you will see that their situation has not worsened. So we have to talk about another aspect. We will see with Jules that we need to sometimes move the meniscus from the lower to the upper arch, and vice versa. So we relocate the meniscus. On the intraoral views, we see an occlusal class 2 with a biproconation and a tooth discrepancy between the central and the lateral upper incisors. The laterals are very thin, and this is increasing the occlusal class 2. He has a class 2 division 1 by mandibular retinosism with a biproconation in the context of low vertical growth pattern. Moreover, he has a molar dysymmetry and a slight count at the occlusal plane. You can see there. So at first, we have line and leveled under the control of the screws. Thus, we have retracted the inferior arch for incisor centering. The skeletal class 2 has been corrected by the poroscope, and then we placed the class 2 elastics for stabilization. The knee screws have been relocated to the upper arch for the correction of the occlusal plane tilt. On this slide, we can observe the evolution of lateral X-rays at the 3 treatment steps, beginning mandibular protection after arch retraction, and at the end, correction of the occlusal plane tilt. The supine position shows good mandibular growth response with an anterior center of rotation. You can see there's a rotation around this point. And a better alveolar 8 equilibrium. The lower incisor repositioning is about 17 degrees without stripping and only with the teeth extraction. The treatment is performed with good occlusal class 1, and finally, we also have a nice smile with a good exposition of the upper teeth. Here is mine. Sorry, my cat is dreaming. Perhaps you can hear it. Now we know everything about the first situation, and we can start with the situation 2 concerning dolichofacial patients. Here we are faced with hypodivergent patients, and what can we expect from this? In this configuration, we are expecting a mandibular contactile rotation to optimize the growth by vertical closure of the compass, and we can mix maxillary retraction and mandibular protection. As we have seen at the beginning, our choice will also depend on the strength of the mandibular elevator muscles and their capacity to counteract the compensatory molar extrusion. Also, in this situation, we must make best use of existing growth potential. The worse the growth direction is, the higher the necessity is for us to control both anteriorly and posteriorly. Our aim is to obtain a vertical closure by contactclockwise mandibular rotation. So the center of rotation in this case is posterior. Thus, according to the smile line, we can combine upper mini screws and class 3 elastics. The lower arch will do a counterclockwise rotation with an extrusion of the incisors, or we can opt for a schema with 4 mini screws in order to increase the vertical control of the lower part of the face and the smile position. Corentin is a good case to illustrate this situation. We love these boys who are younger looking. Despite his age, he has a lot of residual growth and it's good prognosis. The intraoral views show the maxillar crowding and the full molar class 2 associated with a transverse deficiency. The X-rays are confirming our clinical conclusions. He had skeletal class 2 biomandibular retinoscism and vertical growth pattern tendency. The lower incisors are buccal. So to summarize, he has skeletal class 2 mandibular retinoscism. He is hypodivergent and has alveolar compensations and crowding. We have anchored the upper and the lower arch. We have disliked the upper molar for alignment aids, as well as in the lower arch. The mandibular anchorage counteracts the protector size effect. At the end of the protection, the class 2 elastic takes the place of the process. And here are the outcome with a good class 1 relationship. The X-rays of revaluation on the superimposition are showing a good vertical control of the posterior areas, allowing the contact lobis rotation of the mandible and the optimization of the condylar growth. The lower incisors are anteroposteriorly and vertically controlled, and that's also a key to optimize the mandibular response. So Corentin has grown, his face has changed a lot, and he has a beautiful smile. But we should consider what we would do with incisors in the case of growth failure. Here is the case of Océane. She was a transferred case. She has been treated with conventional techniques without any results. Her mother asked me to treat her with fixed appliances and no cooperation issues. As you can see, she has a full class 2 molar relationship. So she has 15, and we have an unfavorable growth prognosis. The process has been supported by a hook anchored with the meniscus in order to avoid the progonation of the incisors. We have obtained the occlusal class 1, and it's still stable after 2.5 years. But we might be worried about the incisor situation because we have males like all the arch, and there is a little labial bone. The cortical bone is very thin. So, to avoid the bone thinning due to the vestibular version and decentering of the mandibular incisor, you can reduce the protection duration. In order to do this, a combination of maxillary retraction and mandibular protection with good vertical control is a good solution for a full class 2 relationship. Another way is to reduce the wire to a round section on its anterior part and anchor it to the meniscus. You will avoid the forward movement of the crown, and you will obtain a backward movement of the apex. It's the expression of the momentum. When you have a backward movement of the apex, you have less periodontal risk. In this case of class 2 division 2, in a context of bioretinosum, the growth wasn't good enough, and we have accepted alveolar compensation. But I didn't want to take a risk for the roots. So I have reduced the wire in a round section regarding the incisors to allow a controlled version. The aim is to move back the apex. You can see it now on the last X-rays and the superimpositions. So, in conclusion now, and to summarize the main ideas of this presentation, we know now that the control of the mandibular incisor is a prerequisite indispensable to the mandible response to our class 2 mechanics. It's an absolute goal in order to respect the periodoncium. Part of the occlusal pain control is a condition to functional response and aesthetic enhancing. Sagittal expansion and mesial leeway of the arch are obstacles to mandibular growth and do not ensure stable correction of facial aesthetics and smile attractiveness enhancing. Keeping alveolar compensation is like putting the brakes onto the mandibular growth. As we come to the end of my presentation now, I would like to thank you for your interest and attention, and I would like to take this message home with you sometime, it is good to go back to the classics. Our old masters always told us to control the mandibular incisors to have the best results. They had a perfect understanding of the growth process, rotation, and typology, but they had a lack of tools. Nowadays, with TADS, we have tools, and we must make best use of them to optimize the existing levels. Thank you.
Okay, thank you very much.